Over the past 30 years, low and middle income countries, LMICs, have spent enormous amounts of time, effort, and money to train health workers on adolescent health with disappointing results. LMICs need to go beyond training to improve and sustain improvements in health worker performance. That is the focus of my presentation today. Namaste. My name is Chandra-Mouli. I worked for the World Health Organization from 1993 to 2023. I retired from WHO in August 2023. I continue to work on adolescent sexual and reproductive health and rights, on my time and on my terms, on issues that interest and concern me. What do adolescents need to grow and develop in good health? Two complementary sets of activities. Firstly, efforts to identify and address health compromising attitudes, behaviors, and health problems when they arise, and to prevent these problems through the provision of information and skills, the provision of health and counseling services, and the creation of a safe and supportive environment. And the other set of activities are to promote interpersonal development, to build their competence, their confidence, their connections with the people and institutions around them, their care for the people around them, and their character. Who needs to contribute to adolescent health and development? It's useful to see this in an ecological framework, beginning with adolescents themselves, the people they are in everyday contact with, such as their parents and siblings, the people they are in regular contact with, such as their relatives, family friends, teachers, and health workers, and the people who touch their lives without coming into direct contact with them, such as sports figures, musicians, and social influencers. As you can see, health workers figure in this list, but there are many other people who contribute to adolescent health and development. 3 points about health workers. Firstly, a trained and supportive health worker is a crucial component of an adolescent-friendly health service. In 2 ways. As a service provider, they can help adolescents, well adolescents stay well, and ill adolescents get back to good health. As change agents, they can help community members and leaders understand and respond to the needs and problems of adolescents. My second point about health workers is that judgmental and disrespectful behaviors by health workers are a critical barrier to adolescents seeking health services and obtaining health services, particularly sensitive ones, such as those relating to sexual and reproductive health and mental health. Some health workers realize that they do not have the knowledge and skills they need to engage and serve adolescents, and that their behaviors are not always appropriate. Other adolescents are not at all aware of these issues. In our discourse, we speak a lot about improving health workers' knowledge, attitudes, and skills in order to improve the way in which they provide information and services. But we do not pay enough attention to the question of whether health workers are motivated and committed to do what they are mandated to do, paid to do, with the knowledge, attitudes, and skills they already have. This worrying study by the World Bank showed that health workers whose competencies had been built in managing childhood illnesses and tuberculosis and demonstrated their competencies in the presence of a named evaluator, then performed very poorly when assessed by evaluators who pretended to be patients. So they knew what they needed to do, but chose not to do it. While we must press health workers as a group to do better, and while we must hold them accountable for their actions, we must also acknowledge that health workers, not all but many, are demotivated, demoralized, and disempowered. Many of them are forced to work in appalling conditions. They do not get their salaries and allowances on time. They are not listened to and treated with respect. And increasingly, they are physically and verbally attacked. While this does not excuse their performance, this contributes to explaining their performance. And these are things that we need to address if we want to improve and sustain improvements in their performance. So let's move from a problem identification and definition to approaches to addressing these problems. Again, 3 points. What do we need to do differently? Firstly, we must stop carrying out poorly designed and poorly delivered training programs not aligned clearly to the tasks that health workers need to carry out. Poor quality training in content and in delivery does not lead to improvements in competencies in the workshop setting. Secondly, we must move away from using training as the only approach to improving and sustaining improvements in health worker performance. Training alone does not lead to building competencies and ensuring competencies that are gained in the workshop setting to be applied in the workplace setting. Thirdly, we must implement a package of proven approaches to build the abilities of health workers through training, retraining, and the provision of desk reference tools. Enable them to perform to the best of their abilities through the provision of equipment, medicines, supplies, and strengthening referral networks, two-way referral networks, and motivating them to perform to the best of their abilities by creating good working conditions and providing them with non-financial incentives. The glue that will hold all this together is supervisor support through supportive supervision and mentoring, and peer support through collaborative learning and collaborative problem identification, problem definition, and problem solving. We must hold service providers accountable to their supervisors, to their peers, and to their patients, including adolescents. Adolescents have shown that they can play a useful role in setting up and using feedback systems and in working with health workers to discuss problems in a non-confrontational manner to co-create solutions. Improving and sustaining improvements in health worker performance requires complementary actions at different levels of a health system, from the national through to the province or state and district to the local levels, as shown in this slide. There's a growing move to incorporate these different actions, which can be seen as bitty and disparate, into health systems, so that these actions can complement each other and reinforce each other to make health systems adolescent responsive, adolescent friendly. There are efforts to change the way training is being done by using blended learning approaches combining digital and in-person teaching and learning, by using whole of facility orientation and training so that health workers of different cadres are trained along with support staff, and high frequency, low intensity training. This is in recognition that the standard model of bringing health workers out of health facilities, holding them in a residential center for 3 to 5 days, training them and then ticking off saying health workers trained, competencies built, is not working. There are also ways to change the way in which performance is assessed through audits and supervision done by health facility managers who are engaged to peer review the functioning of other health facilities around them and to have their own health facilities assessed by their peers. Another approach is self-assessment and external assessment that was developed by WHO and has been used by many other organizations. Both these approaches use an agreed upon short list of quality criteria for use in a cyclical quality assessment, quality improvement process. There is also a growing move to bring trained health workers together in collaborative learning approaches, to share and learn from each other, to work together to identify, define, and solve problems, and together to find solutions. This approach is intended to empower health workers, to take charge of their facilities, to motivate them to do the best they can, and to draw upon the wisdom of their peers and their own wisdom. The whole approach really moves from a punitive, you're not doing this approach, to a praising and recognition approach. It sees health workers as individuals with thoughts and feelings, needs and wants, hopes and aspirations, but also as professionals who are mandated to carry out a task and are paid to do so. The feasibility and acceptability and promise of this approach has been demonstrated in a project in Moldova. We have documented the process and the outputs of that. The effectiveness of this approach has been proven in an intervention study in the context of implementation research in the Democratic Republic of Congo. This is now being rolled out in Burkina Faso. We would be very glad to discuss this further with you if you're interested. I'd like to conclude with 5 points that I made in this presentation. Firstly, health workers have an important contribution to make to adolescent health along with a number of other players. Secondly, health workers have specific contributions to make that others cannot make. Thirdly, we are not preparing and supporting health workers to do what they are required to do properly. Even though there is stark evidence from different contexts over a long time period that the approaches that we are using to improve and sustain improvements in health worker performance are not working, we continue to use them. There's growing evidence of new ways of doing this, of ways that are feasible, that are acceptable, that are effective, and not necessarily more expensive. The challenge for us is to try out these new approaches and see if they can work for us in our context. I invite you and I challenge you to do so. Thank you and namaste.